Welcome to the Berlin Science Week talk here at Humboldt Lab. My name is Julia Vismann, and I'm a journalist and I'm host of the Talking Science podcast of Berlin University, Charité, Global Health, and RBB. And the idea of this podcast is to invite two people from two different disciplines to explain and to talk about one topic. And in one episode of the podcast, I met vaccine researcher Leif Erik Sander of the Charité and risk researcher Markus Feufel from the Freie Universität Berlin to talk about vaccination willingness. Therefore, I talk about this. They said two simple things that emphasize the problem of the debate, actually. Leif Erik Sander, for example, said, vaccination is the only solution to stop the pandemic. But the risk researcher Markus Feufel said, the problem of vaccination is healthy people have to take medicine for a disease they don't have. The case numbers of COVID-19 infections increase at the moment. In Germany, we have the biggest and the highest incidence of COVID-19 infections since the pandemic began. But approximately 1/3 of the German population is unvaccinated. In Spain or Italy, far more people are vaccinated, and they have a far less COVID-19 infections in the population. We want to talk about how to increase vaccination willingness in Germany and want to look at the pandemic as a global phenomenon and multilateral solutions instead of vaccine nationalism. So we have a very interesting panel for this. I want to introduce to you Professor Heike Klüver, Professor of Comparative Political Behavior at Humboldt University and Principal Investigator of the Cluster of Excellence Contestations of the Liberal Scripts. Welcome. Thank you that you are here. And next to you is Dr. Katrin Schmelz, postdoctoral researcher, Cluster of Excellence and Politics of Inequality at the Universität Konstanz. Welcome.
Good evening.
And next to you, Professor Mujaheed Shaikh, Professor of Health and Governance at Hertie School. Welcome, Mr. Shaikh. And Dr. Martin Bergfelder, Head of Corona Taskforce at the Federal Foreign Office, Germany. Welcome. So, Heike Klüver, you did a study with the question, what incentives can spur COVID-19 vaccination uptake? Among a lot of German people, more than 20,000. So what's your main result?
Right. For this, we have a couple of slides prepared. If the assistant could put this up. But maybe let me start already.
Yes.
Yes, just to explain, we have conducted a survey in March that was fielded. It's a representative survey among the entire German population. And we were interested in the question which strategies could be employed in order to increase vaccination. At the time, we were a little bit laughed at because at the time everyone was willing and keen, at least it felt like it, to get the vaccine, right, to get the shot.
It was really difficult.
Right, actually it was quite difficult to sell. There were a few journalists, a few colleagues of yours who sort of immediately realized the potential of the question. And hence we've conducted this study. And it's not only a survey, it's also a survey experiment because we were interested to really identify the causal effect of different strategies on the willingness to actually get the vaccine. In particular, we have tested 3 different strategies. So the first was financial incentives. So we were interested to what extent people can actually, or we can increase the willingness to get vaccinated by offering financial remuneration. And here we varied between 25 and 50 euros. We were also interested in the question to what extent the so-called reduction of transaction cost could have a positive effect. Remember, at the time, vaccination was only possible at very distant bureaucratic vaccination centers. And we were wondering to what extent vaccination at the local doctor could actually increase vaccination uptake, which is basically a proxy for making it as easy as possible for people to get vaccinated. And thirdly, we tested the strategy of granting freedoms only to vaccinated, so also now commonly known as 2G. And if you can now show the next slide, I can show you what we found out. That is the old version. If you just carry on and carry on. I would have loved to present, but probably it's a bit too long for today. Okay, so here you see the results that we found. On the left-hand side, you essentially see the estimated effect on the probability to get vaccinated for the different strategies. So left for offering them 25 euros, then followed by 50 euros remuneration, and then freedoms, which is essentially 2G, so freedoms only to vaccinated, and then the local doctor's treatment, which is essentially a proxy for the reduction of transaction cost. And you also see the results split by different groups. So red is all, then the acceptant, those who are willing, and then blue, the interesting ones, refusing, and the purple, the undecided. And what you can see is essentially that the effects are greatest among the group of undecided citizens, and most pronounced we find an effect of offering either financial remuneration, but it wasn't sufficient to just provide 25 euros, only 50 euros worked. So I was famously interviewed at some point over the summer where a sausage, like in Thüringen apparently was done, would actually help getting people vaccinated, but that is not sufficient. We really need a sufficiently strong motive. So here 50 euros was doing the trick. And then granting freedoms could increase the vaccination probability and also the local doctor's treatment. If we put this all together on the right-hand side, you can see now, take into account the size of the different groups at the same time, we could reach a vaccination rate of about 75% if we apply all the different strategies. You can show the next slide now. Okay, what we also find is that the strategies work differently in different groups. The reduction of transaction costs, so making it as easy as possible to get vaccinated, is most effective for elderly people, whereas the incentive of 2G, getting freedoms only for the vaccinated, is most pronounced among the group of younger respondents. Next slide. Okay, and this is actually part of a broader project. Altogether, we've conducted or will conduct 5 waves. This is a result from the September wave, so 6 months later. And here we were interested in the question of whether the citizens in Germany support 2G, and what effect this has actually on trust and also on the probability to get vaccinated. And what we find, importantly for our debate today, is actually that the probability to get vaccinated among the group of refusing and the group of undecided is not significantly increasing with 2G. So contrary to what is currently discussed, we don't find such a positive effect. What we do find is that the majority, though, of the society actually supports 2G. So politicians have a difficult choice to make. The majority supports 2G. The vaccinated people will actually have an increase in trust when 2G is implemented, whereas those who are against vaccination, they don't want to get 2G, they will further lose their trust in government, and they will most likely not be vaccinated under 2G.
Okay. So, and you followed up the study or the survey, so what are your new results?
This is actually the new results. That was the September results, exactly. The first slides were now published in PNAS, an American journal, and this is basically the result of a paper that we're hopefully submitting this week.
Okay, so it's brand
new, exactly. And this is really the September results.
Okay. Was it, what was astonishing for you about these new results?
Well, I actually thought that 2G could have an effect, could have a positive effect. We did find this in the March wave, right? But in the March wave, the share of undecided was much larger. At the time, we had about 16% undecided citizens in the entire sample. Now we only have 4% undecided citizens. And we just don't see that this is actually not working again for the remaining share of undecided or refusals.
Okay. What that means for the actual situation now, we can discuss that later. But I would like to turn to Katrin Schmelz. You also did a very interesting study, overcoming COVID-19 vaccination resistance when alternative politics affect the dynamics of conformism, social norms, and crowding out. Your latest data are from May, I guess, this year. So what is your main result of your study?
Yeah, so from the beginning of the pandemic, we asked representative samples of about 4,000 Germans to which extent they agree with being vaccinated in case vaccination is voluntary, but strongly recommended by the government, and in case vaccination is enforced and checked. And we implemented these questions in 3 waves, coinciding with each wave of infections. And the special thing about this study, I think it was also in your study, is that is a panel, which means that we had 2,000 of exactly the same people, the same respondents in all those 3 waves. And this is important for our study because we can see whether individuals change or not, and if so, what determines them changing. And for us, a surprising result when looking at all the 3 waves was that those consistently opposing vaccination are just 3.3%. And when we want to talk about how to increase willingness, I think we first have to understand how much room is there to increase. Mm-hmm. And knowing that these people, so the kind of hardcore of opponents is so small, this gives us some hope to have
small but very loud.
Small but very loud, yes. We overestimate the share, that's definitely true. And this share applies to voluntary vaccination. When we look at vaccination in case of enforcement, we see a much more substantial share of more than 16% consistently opposing across all the 3 waves. Mm-hmm. And when we want to find out why is that, so many people have the feeling, oh, it's the migrants, it's the females, it's the low educated, but this is not what we see in this study. So sociodemographics of this kind do not predict being consistently opposed, and they do not predict moving away from opposition to willingness. But what predicts that is changes in beliefs, like trust in government and in the effectiveness of the vaccine. Mm-hmm. So what we conclude from that is that, there is some room for persuasion and education. Mm-hmm. Now, when we look at each single wave, you can go down on the slides. Yes, we talked about that and also about that. You can please go to the next slide. Yeah, so when we look at each single wave, we typically observe what other studies also see, a substantial share of opponents, between 15–20%, depending on the wave. And in case of voluntary vaccination, we see that 2/3 already from the beginning of the pandemic were willing to get vaccinated if it is voluntary. Now, when we look at the enforced case, please click again. Click again, please. We find that willingness to get vaccinated is much less in case vaccination would be enforced, but opposition is much, much larger. So I think the government's decision to have vaccinations voluntary from the beginning was a right decision because of these 40% of opposition. We would have to force much more people against their will if vaccinations would have been enforced. But you could say, okay, that's clear, people don't want to be forced, but that's not true for masks, for example. In the case of mask wearing, we don't see this difference. We don't see this crowding out effect. That's the technical term, or we also call it control aversion or reactance. The idea that you have some voluntary motivation, but if you are forced, you lose your motivation. You don't want to anymore. And this seems to be particularly strong for vaccination, but not, for example, for mask wearing. Yes, and an important finding also is that trust in government matters. The more people trust in government, the more they are willing to support policies, not only vaccination, also all the other COVID policies. People who lose trust, lose their compliance or their willingness, and the more people trust, the less enforcement can hurt or can destroy motivation.
Mm-hmm. So Heike Klüver said there were no positive effects of 2G, but what do you think about mandatory vaccination after your survey?
After that, I think
because 2G is kind of a mandatory vaccination because you get freedom back.
And what you see in this comparison here can be a reason why this surprise pops up that 2G does not work, because there is this crowding out effect. You could say now everyone who is willing, who was in the green bar in the first row, he is already vaccinated or she, so we cannot destroy motivation anymore by making it mandatory. That's true. But what is also true is that the German government has announced from the beginning that there will be no vaccination or no enforced vaccinations in Germany, also not for professional groups. And we see that trust is so important for willingness, so making it mandatory now would have the cost of also losing trust, but still, I mean, we have to consider options. We have to put all the options on the table and see what it means.
And we have to try, and it's like a lifetime experiment.
One thing to emphasize in this study is the way we ask the questions. We did not ask about actual compliance, because most Germans would say, are you forced to, do you get vaccinated if you are forced to? Yes. So that's not what we learn from. We want to know about people's attitudes behind vaccination, and therefore we ask, do you agree with being vaccinated? And you could get vaccinated because you are forced to, but still you don't agree with it. You do it against your will, and this then would be the opposition.
Mm-hmm. Okay. And is there, could it be that the people get used to it, like with wearing the mask? So that it's there's no other option, so we just
don't
have to
see
take
this
it?
change across the 3 waves.
Okay.
So it looks basically it's kind of stable.
Okay. Thank you very much so far. So Professor Shaikh, as a health economist, you're not looking into Germany, but also look at the global situation of the pandemic. So, and you also did a survey. So what are your results of your study during the pandemic?
So we are currently working on a theoretical model in terms of vaccine pricing, so it's not directly related to willingness. But a lot of what we are going to hear today is, things that you may have read online, in the media, you may have heard through academic talks, so it's going to be probably a lot of it will be repeated, but that's the whole point of it. You have to reiterate until you drive the point through. So what I will be talking about mostly is 3 sort of stylized facts when you think about vaccinations, because what we're talking about is how do we get everyone, vaccinated? How do we get 100% vaccination rates? But we globally, yes. What we need to understand is that it is very, very difficult to reach that 100% vaccination status. And there are reasons for that. The first itself is to do with the nature of the disease that you're talking about. So as you see on the slides, the first is the prevalence elasticity of the demand for self-protection. So what happens is whenever there is, a disease out there, people demand more protection for themselves. As a result, they take all the possible measures they can to avoid, being affected by that disease. So it could be, for instance, hand hygiene, social distancing, and vaccinations. What happens as a result is there is less disease. In response to that, when there is less disease, people feel less threatened. And the ones that are not vaccinated are going to think that, well, the disease is going down, so I don't need to get vaccinated anymore. And then you see this drop in vaccination rates, which means less protection. As a result of that, you again observe the disease increasing in the population. So this ends up being, a vicious cycle where there is essentially no end to it till you actually get a substantial number of people vaccinated. Now, because I look into issues more in low and middle income countries, I will try to sort of contrast it a bit with what happened in Germany and other countries, other high income countries. One of the big things that, for instance, I come from India. So in India, what happened was there was a gross miscommunication in the beginning of how we're dealing with COVID. So the government basically came out and said, we've essentially conquered COVID. That's what happened in the first wave of COVID. There's this declaration of victory over COVID. It was all over the newspapers. As a result, you make people feel that the disease is not as threatening or it's not there anymore. And then the demand for vaccination automatically drops. So that's something that can affect vaccinations. There was also another thing that around happening in the media about this false sense of immunity of Indians and other individuals in South Asian countries, where the idea was that we already have so many diseases, and in a way we're used to them growing up, So we have this sense of immunity, and that false sense of immunity also drives down this demand for self-protection. So that's one of the reasons. The second reason in most of the developing world is to do with what we call competing mortality risks. So of course there is a risk of death because of COVID, but there are other diseases out there that are probably also very life-threatening. As a result, individuals and households decide whether to invest in those diseases or to invest in something, preventive action for the disease that we're talking about right now. So it's a private investment that you have to make, which leads to the point which I think Dr. Klüver also, pointed out was about transaction costs in a study, right? So what are the transaction costs for these individuals? It involves effort, it involves time, it involves, going to the local doctor, or even there are remote villages in India where, traveling to the doctor is so difficult. So all these transaction costs means that there is a huge amount of private investment that individuals have to make. Now, the situation in India is not like what you have in Germany. If you get a shot and if you fall sick for 4 or 5 days, you lose a lot of income. That's problematic because there's a huge number of people below the poverty line in India that cannot afford that. So that's obviously a financial loss. On top of that, vaccinations in India were not free. You had to pay, and it could range anywhere between €4 to something over €10. That's sort of a negative financial constraint, or a negative financial incentive or disincentive, if you call it that, in India. So that was another problem in India. So these competing mortality risks and the transaction cost theory with it is also problematic for vaccinations. The third aspect is to do with, and this is quite common in the public health literature, is what we call the 5 C's of vaccination uptake, which is to do with confidence. So whether you have confidence in the government, whether you have trust in the government, whether you have trust in the vaccine itself, how effective, how efficacious the vaccine is, what are the side effects of the vaccine. So confidence itself plays a big role in vaccination uptake. The second aspect is to do with calculation of risks and benefits of the disease. So are you in the situation where you can, or are you even capable, do you have the cognitive ability to calculate the risk versus the benefit of vaccinations? Also with regards to, in terms of the constraints that play down, the financial constraints, the cost of time and money. Complacency is another factor which ties in with the first part that I mentioned of how threatening the disease is. If people think the disease is not threatening, they are complacent. And we had that a lot during COVID. Some people even said that there is no COVID. This disease doesn't exist, it's all fake news and so on. So what is the threat of the disease? The fifth factor is collective action. Do we collectively feel responsible? Are we willing to vaccinate to protect the other person? So all these factors eventually tie into what kind of a vaccination uptake or vaccination willingness that you will have. That brings me to the next point. Can we have the next slide, please? Yeah, I think it is very important as the government or the policymaker to think about what is your objective. Do you want an active demand for vaccination, or do you want passive compliance of vaccination? Those are the two things that you need to focus on. The first one, active demand, looks at a more long-term perspective. Once you raise demand of people in terms of building trust, in terms of adequate information sharing, in a way that they can process that information appropriately, provide them with the right risk-benefit assessment, that has a more long-term effect. So it's not just about COVID. In the future, if you have any other disease, if you focus on active demand of vaccinations, vaccination willingness, they are likely to get vaccinated in the future. Yeah. Mm-hmm. The second part is passive compliance, as you mentioned, whether mandatory vaccinations are good or not, whether they will work or not, other exclusionary measures, and penalties as well in some cases. To what extent is it going to be a long-term strategy? I really don't think it is a long-term strategy. In fact, if anything, it only damages the cause of vaccination willingness. You are alienating a group that already thinks, especially the undecided people, right? The second thing I think you need to look at is also the heterogeneity or the differences in the vaccine attitude. It's not someone that is, willing to take any vaccine versus someone that is going to refuse to take a vaccine. It's a spectrum where you can be anywhere on that spectrum, from complete refusal to complete acceptance. When we say complete acceptance, we're saying no matter what the disease is and what the vaccine is, you will take it without any questions. Complete refusal is no matter how threatening the disease is or how effective the vaccine is, you will just refuse to have that vaccination. And you're somewhere in between where you have this vaccine hesitancy. You may be vaccine hesitant, and you can be vaccine hesitant. A population can be there can be a baseline vaccine hesitancy, and there can be a reactive vaccine hesitancy that reacts to news items, news articles, and so on. So And you would have to engage, with the different populations, and you would have to use different strategies with these populations. I think Heike Klüver is the expert on that, so she studied that in her study. She knows what groups respond to what kind of measures. So I think you can't have a one-size-fits-all, policy in any case, and those are the aspects I think we need to first discuss, especially on what is it that you want, active demand or passive compliance. Mm-hmm. Thank you.
Yeah, thank you very much. But was there a change in the time in India because of the effects of COVID-19 and many people who suffered and died?
Sure. So we had the first wave of the disease when we did relatively well, and then we declared that we've achieved victory over COVID, and then the second wave happened, which was the most disastrous wave that everyone must have seen in the news, where thousands and thousands of people died. There was no space in crematoriums to burn the bodies. There was no space in graveyards to bury the bodies. So, of course, now one might say that this is just exaggerated, but there were also other scientific articles published on it that used satellite imagery to see sort of, the funeral pyres burning, and then counted on what the death rate might actually be in India. So yes, it was a terrible situation. In terms of the vaccination approach itself, we had different strategies to do that. We first started with vaccinating frontline healthcare workers. That was also sort of doubts raised on that because we had two vaccines in India. We had the in-house vaccine, the Indian vaccine Covaxin, produced by an Indian company, and then we had the AstraZeneca vaccine. And healthcare workers were not given a choice as to which vaccine they wanted, so they were already apprehensive about it. But after healthcare workers, the population group was the older population over the age of 60. And a big problem that we had was, of course, we've got a huge population, right? We just didn't have enough.
It's not like Germany.
Exactly. So you also have to account for those aspects. So there was just, we didn't have enough resources or enough vaccines to do that. There was a lot of, again, we're also in a way a federal system. We've got multiple states, and then the states sort of started competing to get, a certain number of doses of the vaccine. So this led to the initial, low uptake of the vaccination. The process itself to get registered for the vaccination was difficult. My parents are both uneducated, and they couldn't go online and register for the vaccine. I couldn't register for them over here because the website wouldn't open in Germany. So there are these. One thing is thinking about increasing willingness. The other basic aspect is, do you have the fundamentals right, which is the access to the vaccine, the ease of getting the vaccine. And once you overcome those, then we are in a position to think about, okay, now how do we increase the willingness of people? So yeah, we had those issues in the beginning.
Okay, yeah, because we shouldn't forget that everything was really fast, and even the development of the vaccination and everything, and we might forget about that. Thank you very much so far. The last one in the row is Dr. Martin Bergfelder, coordinator for the foreign policy dimension of global health issues and head of the Corona Taskforce of the Federal Foreign Office Germany. So what were your main challenges for the Federal Foreign Offices in the beginning of the pandemic?
Okay, in the beginning of the pandemic. Well, actually, in the beginning of the pandemic, I'm focusing on the international aspects, right? So I'm not responsible for our staff, but that's also an issue. So staff stranded, passengers stranded, German tourists stranded, also how to get vaccines to our staff in missions abroad. That was a challenge at the beginning, so at least when the vaccines were available. But especially at the beginning, when I came into the job, 3 weeks maybe after the pandemic has started, or 4, I found a long list of hundreds of countries asking us for help, asking us for oxygen, for masks, for what have you, treatment, ventilators, and there was no process, nothing. There were just all these requests sitting there, and we had to struggle and see, okay, where can we get this stuff? How should we send this there? And who should we prioritize to help? That was at the beginning when we were not able to also share vaccines. Because first of all, we didn't have any. And then there's always also national demands, obviously. So that was the beginning. And then we worked on...
One question, did you have masks to give away? I thought there was a problem also.
Well, actually, let's just say we have more than enough masks now. But okay. I can say that we are still, I think that the first delivery that we did, or the first big package, we decided to do this through the WHO. And I think and these were masks, a lot of masks that were still in China, so we had already bought the masks, but they hadn't been shipped to Germany, and in the meantime there was enough in Germany, and production was also uptaking. But we are still, these are still being delivered. So this was kind of a decision we took more than a year ago, or even longer, and not all of these masks have still arrived in the most remote areas. It really takes time, and there are problems in the logistics, in global transports. So some places we haven't reached yet with this multilateral effort. But I think we can be quite proud. We think we have helped over 100 countries now across the world with medical supplies. Obviously, it a bit follows the waves of the disease also. So at the beginning, it was European countries asking for help. Then it spread around the world. Then with the next wave, it came back to European countries asking for help. Then it went back to the rest of the world, and now we are back again at European countries also asking for help, which should worry us besides any statistics, and that the disease is far from over. So the Eastern Europe especially is a problem at the moment. Hospitals are under heavy pressure, and so that's an issue.
So what do they need? Is it medicine, or is it vaccination? Is it?
I think I mean for the vaccination is a different thing, and I'm happy to talk about that also. I'm just talking about called PPI or ventilators and that stuff. I think it differs around the world. Obviously, in Europe there's no issue of lacking of vaccines anymore. So every European country has enough vaccines, so they're not asking for vaccines. What they're mostly asking for is ventilators, or even better, oxygen concentrators, medicine, so monoclonal antibodies and what have you, in terms of those few therapeutics that exist currently and are available for treatment. And also some are asking for either medical teams from Germany being sent there, or patients being evacuated from the country and taken over to Germany. But it's part of the everything was short at the beginning, was in demand at the beginning, and is now less in demand. So there are still countries asking for masks, but that is not a very popular request anymore. Or simple hand disinfection was also in shortage. And now we have countries asking for everything that is related to the vaccine. So, how you call Spritzbesteck, needles, syringes. For example, for the mRNA vaccines, you need special syringes, and they are not available at the market everywhere. Then for some mRNA vaccines, you need special diluents. So, and these diluents are not available. So there are many small items that can cause a problem even if there are enough vaccines. So that was the PPI. Then we started, in parallel to our German European procurement of vaccines, we started to set up this multilateral platform, the ACT Accelerator, the COVAX platform. Some of you might have heard about that. And the idea was basically everybody gives money, and then we pool the demand, and then we buy enough vaccines to at least cover 20% of the population worldwide, which was round about an estimate frontline healthcare workers plus vulnerable groups. That should be roughly 20% around the world. We gave a lot of money. We gave a lot of political support. The initiative took off quite well, but we also have to be realistic in what it has achieved and what it hasn't achieved yet. We are not yet at the target, so and we probably missed the target end of the year.
What target? Or
to vaccinate at least 20% across all countries. I'm not talking about 20% worldwide. We are already well over that, but to vaccinate 20% in all countries.
Okay.
And the next goal that we have is to vaccinate 70% worldwide in all countries by mid-2022, and this will already be a challenge. In principle, there are enough vaccines. So if you look at production, if you look at new production plants coming in, if you do the numbers, you have enough vaccines to vaccinate everybody around the world.
But what is the problem? Distribution?
Distribution is an issue. So some countries obviously, have ordered vaccines for 3, 4, or 5 times their population. Others are at the end of the queue. This is why we have started since a few months, and this actually keeps me quite busy to also donate vaccines, because it's a very complicated process. So whatever we don't need in Germany in terms of the vaccines that either we have in the country or that we are still getting from contracts, because there are still vaccines coming in, we directly give them to other countries, and especially to the poorest countries, obviously. So for a while, the issue, or really still is, get enough vaccines everywhere. As you have said, first of all, the basics, we don't have to discuss hesitancy if there's no vaccine to take. But we can see that in many countries we are starting to approach or to reach the point where other issues become more important. So you have countries with very low vaccination rate in Africa, for example, that are receiving now quite substantial amount of vaccines and are still struggling to actually get these shots in arms for various reasons. I mean, there are logistical issues. If you talk about the mRNA vaccines, you need a special cold chain. I have talked about syringes and what have you. Then, as you have said, remote areas, it's easier to reach the capital where the big plane from UNICEF lands and ships in the vaccines, but then from there it's up to the country to deal with that. Then you have countries with the political problems or civil unrest and all these issues. Then you have also distrust in government. Then you have hesitancy, you have fake news everywhere. AstraZeneca was not a good story, so to say. It has also in some countries, people don't want to take AstraZeneca. Because they have read from the troubles in Europe or the discussion and they don't like it. And then there's the issue of shelf life. So some of the vaccines that are shared or that are being shipped have quite a short shelf life, and countries are struggling to get these vaccines out beforehand. But then there are also other factors where we are still not sure actually what it is and why. So there's a long watch list from COVAX on the most critical, 20, 30 countries where the rates are dropping or where they are sitting on the vaccines, and every country is a different story. And there's no one-size-fits-all answer to this, I think. And it's also not liberal countries doing it better than authoritarian. I think that would be too simplified. Too easy. To say. Just one thing to add, and you have to stop me because I will not finish.
I think it's very interesting.
I think what has been mentioned also, and I tried to read some studies or at least some headlines before I came here, because usually vaccination in Germany is not my file, right? But I think I read that many people that are now still refusing to get vaccinated in Germany are waiting for other vaccines. So a broad portfolio of vaccines also is important. We currently have the vector-based vaccines, we have the mRNA vaccines, which are quite new technologies both, but there's also the inactivated virus or the inactivated vaccines, in German Totimpfstoffe, so dead vaccines. I think 1 or 2 of the Chinese ones that are currently in the portfolio are inactivated, but this is a very long-term established technology. And I think it was the Forza survey last week where they said it was more or less the only game changer for those people who are very hesitant to actually get vaccinated. that there is a vaccine on an established technology. So we hope that that for Europe also, I mean, there is in the pipeline Valneva, Novavax, and maybe the Sanofi one. And Novavax seems to look quite good in terms of the results. They don't have the approval by the European Medicine Agency, but we have ordered also some quantities of these vaccines for Germany. And you could ask why. We have, you know, enough vaccines, but there is a strategy to try to have a broad portfolio, because this vaccine is especially a vaccine that we hope could convince people that are skeptical right now. Last but not least, I think, you know, those countries in Europe that have suffered quite hard from the pandemic in the first or second wave, there is a greater willingness to get vaccinated.
For example, right? Italy or
Italy, Spain. If you look at these countries, they
do well at the moment.
We have avoided these scenarios in Germany so far. If we had these scenarios, maybe there would be a different approach. Also, I'm not quite sure. And also obviously for policymakers, the question is also, you know, we're basically in a race against time, right? So it's correct to say it's always better to convince people voluntarily to do things. The question is, how long can we wait, actually, right? We have new variants emerging. We can start the whole game again, vaccinating everybody next year with another vaccine, and the winter is just starting in Germany. So personally, I think I would have quite some sympathy, at least to mandatory vaccinate a few, how say it, like frontline healthcare workers or people in, you know,
an important.
If you are in care, in intensive care, I think you should get vaccinated when you treat people. I mean. We have seen that was the tragic in last year, or the biggest tragic. I think all the people
dying. I think in Italy it's a case, isn't it? I think they
were the first.
Yes, they are the first.
And also, I think just today, maybe it was today in the news, Costa Rica, for example, has announced mandatory vaccination for starting with the 5-year-olds.
Oh, okay.
And I think Costa Rica is quite a liberal society, so. I'm not saying it has to be done, but I think we really are struggling. We are struggling to get to a level. I don't know if we ever reach herd immunity, but we are struggling to get to a level where we can somehow manage the pandemic also in Germany.
Okay.
So that's a problem, but I'll stop here.
Yeah, but thank you very much. So, Mr. Schmelz, what do you think? Is it, can you understand this thing about
definitely.
Healthcare jobs?
No, it's obvious that people who work with other people cannot be a danger for them. So there must be ways that they are protected. Or they protect others. That's really no question. The question is how to achieve that. We saw in the US, for example, there are now mandatory vaccinations for government employees and for the police and firemen in New York, for example. That has been in the news recently.
And also for healthcare workers?
Partly.
Partly, okay.
For students, partly. And so there was quite some excitement in the US about the police in New York, for example. And what they observed is that so there was some opposition and news that fire workers called in sick. So sick rates increased dramatically. But last-minute vaccinations then saved the thing somehow. So just the last day before showing up at work, instead of being fired, many people still got vaccinated. And the number of people who really lost their job was in the range of 1% or so. So surprisingly for them, at the end it worked. The problem, I think, is it's not so simple to say, okay, we enforce it and then we are rid of the problem. We know from other studies that enforcing one vaccine decreases vaccination willingness for other vaccines. In particular for the COVID vaccine, it could increase as you saw it, if you get vaccinated against your will, if you are among this hardcore of opponents, if you have to get vaccinated, it could increase opposition to other COVID policies and to the government. And in the long run, we need compliance from people for other important problems of our societies, right? And I think in Germany we have to somehow deal with the promise of the government that vaccination will be voluntary and will not be enforced. Of course, when the promise was made in the beginning, we thought 2/3 is enough to reach herd immunity, and we have reached this level, obviously, but the situation has changed with the Delta variant. So we are in a new situation, and we have to rethink the options that we have at hand.
Mm-hmm. Mr. Shaikh, what do you think, because it differs in the different countries, for example, in India, would that work? Mandatory vaccination for healthcare workers, for example, or for firemen?
I mean, the straight answer to that is I don't think it will work in India, because it is such a vast country with so much heterogeneity in the population. You have people of so many different religions, people that think, speak different languages, they're from completely different ideological arenas. I think I agree with much of what was mentioned before by Katrin Schmelz, and I think in India, and that's not just in India, but in any other context, it's not about what kind of policies, mandatory policies or whatever you have during that disease, but also what you did before that is going to determine what happens next. So, for instance, in India, there was already a lot of distrust in the government. We had, certain laws that were called into the parliament on the new Citizenship Amendment Act and so on, right? That could actually, for instance, could strip you off your citizenship according to some. So people were already skeptical about what the government was doing, and it was targeting certain minority groups, right? So if you try to impose another thing like this, it is that minority that will absolutely not align with the objectives of the government. So I think it is very situational, it is very context-driven, and I think that's something that must not be missed. What would work in Germany, for instance, will not work in India, simply because of so much, differences in the population, so many differences in the population along other lines. Just one point quickly. Yes, I agree that it is a very small and loud minority, but there was a paper in the journal Vaccine in 2015 that looked at Twitter trends on hashtags of anti-vaxxers and pro-vaxxers and found that it is a small group, but it is on the rise. It was already on the rise around that time. So I think...
2015?
In 2015. It was already on the rise, this group, and we don't know how the situation has changed during COVID. It is a small group, but it may be on the rise.
Okay. But how to motivate people who are skeptical, and how important is the intrinsic motivation in convincing people to get vaccinated?
I think there are studies out there that look at different mechanisms how to improve vaccination willingness. Financial incentives are some of those, monetary, non-monetary incentives, but there are also other treatments that are carried out, for instance, in these studies with respect to letting people know about pro-social behavior and telling them about the this pro-social nature of getting vaccinated. There is very limited evidence that finds that these things actually work. For someone that does not want to get vaccinated, will not get vaccinated. So yeah, I mean, even passing on the right these kind of attitudes along or information along doesn't work with this group. What I think we must understand is one thing is we want to convince this population. But are we conveying it in the right way? So you should first think about conveying and then convincing. We directly jump on to convincing people without understanding how to convey this information to them. I was just thinking. Initially, we heard about the R value. It's 2.0, it's 3.0, it's 1.5. We understand that as scientists. How is someone that has no idea about what this is going to understand that information, or even think about what that means in terms of the threat of the disease? If they don't understand that, they will not think it is a dreadful disease, and they will not think they need to get vaccinated. So I think conveying the information in the right way is very, very important.
Mm-hmm. How could we do it, Mrs. Klüver?
Yeah, I think what has been mentioned is, I think, very important that we have a timing problem here, right? And that we only have a timing problem, right? Because, for instance, if we go back to Germany, which I know much better, of course, we currently need some reaction of the government, right? We need a reaction that comes quick to really contain the spread of the virus further in order to avoid a collapse of the health system. So even though we now show in the survey experiment that 2G may not work, but we have to keep in mind that this is a survey experiment. So I'm really wondering what's happening now in Saxony. Just this afternoon I was using the latest data from the RKI to actually conduct an analysis of so-called difference in difference analysis to see to what extent the recent policy that was put in place by the Saxonian government, 2G, whether this actually changed the vaccination willingness, so actual turnout at the vaccination centers. It's not significant, but there seems to be a positive trend. So it could be that once you're actually facing the danger of losing your freedoms, of being excluded from social life, the freedoms that we just all were granted, right, over the summer, over the spring, that you're really facing the danger to not being able to go to the restaurant, to the opera, to the cinema, to football, that this could be a game changer, at least in the short run. I do agree that in the long run, this could destroy trust among actually a population that we estimate at 10%, the tough vaccination skeptics. I think you're like 3. We estimate that at 10% in September. So this is a growing crowd that is really skeptical. And this is the crowd that is primarily voting for the AfD, that is having very little trust in government, even before the entire pandemic, that is not trusting the government, not trusting the health system, not trusting the media, that is less educated. And this is a general trend that we find, right? That is a general trend that we find also in general voting behavior, if you look at the results, obviously, of the AfD. So if we do adopt this right now, it could help us increase vaccination uptake. It could also help through a different mechanism, I think, to contain the virus simply by excluding those people from social activities. It could become major spreading events. But in the long run, we're running at a risk of losing these people for other policies in the future, as you pointed out earlier, right? Because it's a core of a certain part of the society that we're already losing in terms of, for instance, the established party support, right? So this is something that we're facing right now, but we do have to contain the virus. So personally, I think that is the option at stake right now.
But isn't there also a risk that more people go to this group of 10% and support them and say, okay, it's, at the moment it works, 2G, but...
Absolutely agree, right?
Next year,
it could definitely result in an increase in vaccination skeptics, but also people that we're losing among the established parties, right? Mm-hmm. Losing in a ecosystem, pushing them towards the ideological extremes of the spectrum. Mm-hmm. But we do have a timing problem, right? Mm-hmm. We cannot wait for another 5 months. And also we have to acknowledge that information campaigns that have been mentioned earlier, there's hardly any evidence that supports that these actually work. Mm-hmm. And now, giving the time pressure, I personally do not think that there's any other information strategy that we could now employ, at least in Germany, to further convince these skeptics. Also, I think the situation in Germany and India is quite different in that regard. We already have a lot of information about vaccines, how efficient they are. So I don't think information levels are really the problem here. It's about trust in government, which we see, which we have seen, which you have seen in your study. And in the short run, I don't think we can change trust in government.
Okay. Ms. Schmelz, you agree?
Apart from destroying it. Destroying trust is fast and easy.
It's fast and easy.
But building trust is difficult.
In the end, it could be really dangerous for civil society. The distrust of the society.
Yes, yes. And again, we need cooperation later now for climate change and whatever for important things. And this is what I'm in a way concerned about. We have to get the unvaccinated, that they are vaccinated soon. I think we first maybe should not focus on the hardcore, but on those who are still open in a way to change their mind, and that's what we saw. There is quite some room. I think you had the in one wave, right? You saw the 10%.
well, the last word in September was 10% vaccination skeptics, radical skeptics, and only 4% undecided by now.
Okay, no, but what we found is that, so in each wave we found between 12 and 20% of skeptics or of opponents, but these 3% are those who are always against in all the waves. So it's not always the same people. That was the 3% about. But in each single wave we have basically the same thing. So yeah, trust is, I think, crucial. Trust in science, trust in government, and I think the media can really help on that. And the media have an easy time to destroy trust. It's big headlines if you can say that there is some risk of a vaccine and there are breakthrough infections, but what does it mean? And I think the media really have a huge responsibility to report in a reasonable way on these topics. I think that's also has quite some influence on people's opinions. And once you have formed your opinion, there is this concept of cognitive dissonance in psychology. So you are undecided, and that's a difficult state of mind. That's stressful somehow. So you prefer to have a decision. But once you have reached your decision, you collect information and weight them such that they confirm your opinion. And in this sense, having a big dramatic headline can decrease willingness, and then people are close to being persuaded and convinced by more relative information. So that's one problem that I see.
But for example, let's take this vaccination breakthroughs. There are vaccination breakthroughs compared to the cured people. It's not big, but there are breakthroughs.
Exactly.
So.
But when I read the headline of, in summer I read something like, just the headline, 32,000 breakthrough infections in Germany. Mm-hmm. That's shocking. Mm-hmm. Nothing else.
Okay.
But it has to be related to infections that you would have gotten or among the unvaccinated, mm-hmm. right?
Mm-hmm. Okay. So, Mr. Shaikh, what do you think? Because when we talk about Germany, it's very special. But what can you learn for your global perspective, for example, from this debate, or is it not comparable?
It is difficult to compare. I wouldn't say it's not. Some things are, of course, similar in both contexts. The trust issue is similar in both contexts. Communication problems are similar in both contexts. But there is something that, for instance, that was done very well in certain parts in India was really regional heads or regional district or village heads actually, ran information campaigns. They went personally out from door to door, trying to tell people, trying to convey the information in the right manner. And because of that, certain villages and certain districts had very high vaccination uptake. It was just as badly done in some other places. So there is, of course, this tailored approach that you can take. So if you are able to identify the different types of groups that you've got in your population and have a tailored strategy, you try to understand what is the reason why they are not getting vaccinated, and then think about what is an effective way of trying to get them vaccinated. I think it works much better than just a one policy that is, let's just get everyone mandatorily vaccinated or enforce vaccinations, for example. So I think that that is something I think personally that many countries can learn from some of the vaccination campaigns in India. What happens in India, and also what happened long ago, was when the polio vaccine campaign was out, celebrities, really popular celebrities, were involved in campaigning for vaccinations. There were constant television ads showing the benefits of polio vaccinations, and I mean, we've seen the benefits of that in India. I think sort of these popular people can make a difference to these. So if there is some way that governments can engage with them and try to get them to convey the message, I think that can work very well as well. And of course, I mean, needless to say, again, building up trust. The question is, how do we build up trust? One thing is, once you say something, follow it up, take some action on it. Don't just say something and never do anything about it. And that's what we see politicians do. There is a lot of promises being made, but not being followed up by action, not just in the context of COVID, but also for other policies, for other areas. That is a way of building trust in the long run. So, just follow it up with action in terms of what you're saying. I think that's good enough to build up trust in the long run.
And to broaden the picture, what could be the learning for global health from all this?
Oh, this is a very broad question, I must say. I mean, there is so much to learn from different countries, right? Like I said, other countries can learn from these little vaccination campaigns that happened in India. I think I agree. The big learning is that we are under a time pressure, as was mentioned before. This is a race against time. But are we going to think long run in terms of what we do now, what kind of impact it will have in the long run? Or are we going to have this very narrow, myopic thinking of we just need the benefit right now? And this is why we are going to just ask everyone to get vaccinated, or we're going to exclude them from civil society. I think it's a question that needs to be thought very carefully because sooner or later you will end up in a situation that will be damaging to society. And then, of course, you can't go in the past and undo what you did before, right? So I think that needs to be very carefully thought. That's something to think about and, as we say, learn from your mistakes. But I don't think we'll be able to, if we do that, I'm not sure of what we will be able to, learn from it in the future.
Probably Mr. Bergfelder, the question to you. So what do you think, how well did the international community so far during the pandemic as a community?
Well, it's not, I think not that bad as it could have been. I mean, in an ideal world, right, we would all have bought our vaccines together at the beginning.
And no
Germany,
vaccine nationalism.
Yes, no Europeans or Americans buying first vaccines for their population, and then
that was really embarrassing, wasn't it?
Yeah, but come on, let's be realistic. Could that ever have? Can you imagine this outside of an academic setting that this would have been realistic? You think German voters would have accepted that we say no, sorry, before we have vaccinated the last frontline healthcare worker somewhere in South America, you will not get a dose. I think that was not possible to do. So I think for the circumstances we have done quite well. We have managed at least to develop vaccines quite quickly. It was an international effort to develop these vaccines. A lot of money has gone into this. Also, we have been able to ramp up production quite quickly. We invested a lot of money upfront in production. So many companies were building the factories while they were still developing the vaccine, and the governments were giving the money to that. So that when the vaccine was then approved, there were already production happening, and we had the doses. So that was quite, I'd say, quite brave approach. And international community is difficult to say. Obviously, several actors have taken several. Or different steps from the European perspective. I think we have been quite open from the beginning. So we have never put in any export bans. So if you look at the numbers, I think we have now exported more vaccines. I'm talking just commercial exports, exported more vaccines from Europe than we have used ourselves in Europe. And we have been all these export things. No, it's not my main file, but they are going over my desk also. And from even before, BioNTech vaccines, practically you can say the whole world, besides India, who has been producing and exporting for a while, and China. But for the rest of the world, all the vaccines, or mostly all of the vaccines, have been coming from Europe. So there was no exports, nothing from the US before they had reached quite a high level of vaccination there. So I think from a European perspective, we did quite well. We could have done better, that's for sure. We were lucky that some of the vaccines we invested in actually worked. We could have ended up with no vaccine.
Yes.
Now we have we have quite a broad portfolio. I would have loved to see more. So we had also some failures, so far, or CureVac, for example, would have made a huge difference if CureVac would have worked at the moment. There are still, as I said, these inactivated vaccines that are still not there. We faced a big problem when India was very hard hit by the second wave and then stopped exporting because the international community, the international answer had relied heavily on supply from the Serum Institute of India. So this is part of the issue. Everybody fully understood that, you know, as I have said at the beginning, same for India, you know, how can India justify exporting vaccines while there is a problem in the country and the people are in dire need? So same for India as for Europe.
An even bigger problem than in Europe.
Russia has done this for a while and China has done this for a while. So the Russians, at least in terms of promising, they have promised a lot of exports while they couldn't yet vaccinate their own people, and they're still struggling with that. Some things we need to improve, and we are working on this. One is also in diversifying production. So we are doing a lot of work. If you look at the next pandemic, for example, some of this will not come into this pandemic if we've managed to finish or contain this by the end of next year. But it's very important that not only in India, but also in other parts of the world, there is capacity to produce vaccines locally. As I have said, in theory, there is enough vaccines for everybody, but if the vaccine production is concentrated in a few countries, obviously this makes others much more dependent on the generosity of others. And I think we have not realized at the beginning how fragile all our supply chains are. And we have only realized this now, and we are still developing new things. As I said, you know, just one example, we have started to donate 10 million doses of BioNTech and to COVAX. And I was very happy and said, great, we have these, finally we can donate BioNTech. And I would now, you know, you COVAX do with the doses what you want, but there are a few countries where I would like to help because they are good friends of Germany and they definitely need these doses. And then there came a lot of requirements saying, no, sorry, because of the manufacturer, you can only give it to these countries. These countries need these syringes. They don't have them. They don't have the diluents. So there's a limit of only a few countries you can give the doses to. And it's very difficult for me to explain then to even a country desk in my ministry or to the country themselves. I think the last year, almost every country has contacted us, or every ambassador has called me and asking me for vaccines. And to tell them, now I finally have something, but I cannot give it to you because, you know, for whatever legal, administrative, technical reasons, that is quite frustrating. And we have seen the same with masks at the beginning, right? Okay. It was a very cheap article, but it could bring the whole world economy to a standstill that we were lacking these masks. And so there's a lot to learn for the next pandemic, but we are still
in a pandemic.
This is the problem, yes. I mean, there's a lot of work going on for the next pandemic, reforming the global health system and the structure. But for example, if you take the G7 presidency of the Italians, who has just finished, the Italians, when they put up their priorities for their presidency, they thought, okay, pandemic will be over, preparing for the next pandemic will be our priority. And the longer they came into their presidency, the more and more they had to backtrack from this because managing the current pandemic was still on. Now, next year we have a German G7 presidency. In theory, we should focus on the next pandemic, but I can already see more and more time being eaten up by actually dealing with the current pandemic.
But doesn't matter if we talk about the current pandemic or the next pandemic. What is your learning at the Federal Foreign Office for strategies to follow in order to develop public trust in international corporations?
I mean, definitely, I think one of the issues that you have mentioned, the idea to look at, you know, what are the influential people among different groups is very important.
Groups and countries.
For example, religious leaders, there are projects with religious leaders in Africa, or there might be tribal leaders somewhere else. There might be special communities where they only listen to special people. There might be celebrities. So all of this can help, definitely. I think churches and religious leaders can play a big role. Not everywhere, but somewhere. And then the other thing, obviously, we have been we have made sure always not to donate anything to anybody that we wouldn't use ourselves here. So whatever.
But AstraZeneca is a
no.
It's a problem, isn't it?
I got vaccinated with AstraZeneca for the first shot.
Poor you.
No problem. It's a good vaccine. I'd say in terms of problems after the vaccination, Johnson & Johnson for the moment seems to be the weakest one, let's say.
It was more about bad communication and...
Yes, I mean for new variants it is less effective. But then in the end also you have to look at, what's your goal. If I would still say that and I'm very proud that we managed to donate every AstraZeneca dose in Germany that was still deemed viable, usable by the Ministry of Health. We didn't leave not one dose going idle in Germany. I'm not talking about those who have been in the Länder somewhere at the doctor, where the Ministry of Health said, we are not sure.
Because that's a problem.
That's a different, we couldn't. But everything that was kind of safely stored and checked by the army to be still okay, every single dose we sent to another country. And I still think that even with one shot of AstraZeneca, there's a great chance that you will actually not die or get into intensive care. So it actually can save lives. And that is very important, I think. And I'm very proud of that, although it takes immense, it's very time consuming, all these processes. So I think that is important, but it's the same for masks and other things. There were some requests, we have these masks here and couldn't you donate them to Africa? There's a problem with the stamping for Europe, but they could be usable for Africa. I said, no way, I'm not to do whatever you want with these masks, but I'm not sending them anywhere. Same for medicine.
Yes.
We're not sending any crazy medicine that is not used in Germany or that is, after shelf life or anything. It just really, I think that is important. And the other thing is we have experienced solidarity and we try to provide solidarity. And obviously our closest neighbors are most important, right? At the beginning of the pandemic, when we were struggling, also other European countries helped us and much poorer countries, even countries far in Asia kind of helped us with stuff. And we're trying to give that back. Obviously, a priority is always our neighbors, but for various reasons. But that's not the only aspect to this. And what is, I think, also important is that we are not, at least as Germany, we are not engaged in some kind of vaccine diplomacy, creating, dependencies. We have seen that with other actors, and we can track that, either new financial or economic dependencies, but also political issues. We have seen countries supporting crazy statements in international organizations, totally changing their position towards several political issues after vaccination deliveries or promises of vaccination deliveries by a few countries. So it is still a geopolitical tool. We're trying to refrain from that, but obviously have to counter this also. So we are trying, that's why we're using COVAX for all this, because they actually have, relying on allocation mechanisms by the WHO and trying to ensure fair and equitable access, and at least making sure that, before one country gets 80-90% vaccines for their population, at least frontline healthcare workers everywhere are vaccinated. That's not easy. I think it's the right way to do. And I could go on and on, but I
Mr. Shaikh, because talking about responsibility and solidarity, how do people perceive responsibility in the pandemic? What's your experience there?
Interesting question. I have two answers, one on Germany and one on India.
Yes, of course.
Because
sorry that I didn't.
No, that's okay. So as you know, we're working with we have worked over the last 2 years on a project called Neustadt with the Robert Bosch Stiftung, where we conducted interviews with a lot of citizens across Germany, and the one common thing that every citizen constantly mentioned was that we want a system that has solidarity as its principle. We do not want anything else but a system where everybody feels responsible for everyone. So I think that's the general belief of people over here. In India, as well, in the COVID symptom survey which was done, it was from Ideas for India, and they actually had one of the top reasons for vaccine, I wouldn't say unwillingness or the delay in getting a vaccine, was that I think other people need it more than me, and that is why I will take a step back and let others have it. So about 31% of the people actually said that in that survey, that I will wait for others to get it. So of course that solidarity and doing something for others, this pro-social behavior, that's also there in the context of India as well. But safety is another concern that most people, almost 32% of them said safety of the vaccine is the topmost priority for us. Once it is established that it is safe to take it, then we will have it. There was a bit of distrust in the homegrown or the in-house vaccine, and people were a bit more trusting towards, I think, AstraZeneca, but they just wanted the trust to be established first. So after that, it's this pro-social behavior, I think.
Mm-hmm. Okay. And Germany? I thought it's...
No, so I can't say specifically for in the vaccine, in the COVID case, but in general, we also did the interviews during the COVID period, and even then, solidarity was the topmost principle that everybody wanted to have in the German system as well.
So, is it also your experience, Heike, Klüver?
Yes, actually, we also have done a second experiment in the March wave, where we looked at support for the allocation regime that we adopted at the time. Remember that we were also following the same principle as in India, that we first healthcare and the elderly, and then only other people afterwards. So basically, everyone supported first providing it to the vulnerable groups, most importantly the healthcare workers and the elderly. And that was something that we found predominantly across all different societal groups in our survey. Okay. So basically the same result for Germany.
Okay. Oh, great. So thank you very much so far. When you have questions, you're invited to ask questions here to the panelists. We have a microphone, and just show your hand. Oh, there's one.
Hello, my name is Johannes Töte from Scripts. We know each other because I helped to organize this panel.
Thank you very much for that.
No, but my question is, I guess the main issue that all of you discussed is really trust. And Frau Schmelz, you also mentioned that the pandemic, any pandemic, is also just an example for any bigger crisis or challenges that may arrive very soon, or is there already, like climate change and other issues that touch global health. So I see the main contradiction between trust, developing and strengthening trust, but also dealing with situations of high uncertainty, of high velocity, where you don't know how developments are going. And we'd like to ask, well, basically all of you, but what kind of structures do we need in public health? Do we need new formats? Do we need a new culture of cooperation between science and the public sector? What could be the main issue to prepare our society and also our state structurally, so that the next pandemic or the next global issue will not hit us so hard in terms of trust? So maybe Mr. Bergfelder, if you like.
Difficult question, I guess. So, what's your idea for a new structure of public health globally?
Okay, I think one of the buzzwords is pandemic preparedness, right? That is very important. So I think also from me speaking personally as a citizen, the idea that at the beginning, you know, the pandemic started, German politicians were saying, these masks, you don't need them. I think that's over exaggerated. And people could, you know, feel that the reasoning for this was because we didn't have any masks, right? And as soon as we had the mask, it was made mandatory. And then I think, you know, if you have the feeling...
There are more examples like that.
Yeah, there are several examples like that. So if you feel that the politicians are not honest because they have supply constraints in the background, that's not a good thing. That needs to change. I think so. What we are trying to do at the global level is try to, you know, improve the structures for pandemic preparedness. So, for example, that there is some kind of very simple question, stockpiling, or that there is a ability or money, surge capacity, I think is the technical term, that if there is a crisis, we can react more quickly. But then, obviously, strengthening the health systems is very important in general. I mean, in Germany, we have probably a problem with, we don't have a problem with technology, but we have a problem with people, actually. No, we have enough ventilators, but we don't have enough, or we are starting to lose the people actually doing the work on the ventilators. In other countries, it's maybe different, but strengthening the health systems is very important. Equity is very important, but that's a big word. The international health regulations, to give them more teeth, I think is important. There are a lot of regulations. There are a lot of, you know, things you need to report if you have a problem in your country, so that the others are alerted earlier. But it hasn't really worked in this pandemic, so try to do it better the next time. You know, I think it's a give and take on this side. But I think to kind of have a new pandemic treaty and a new global system, which is discussed, will be not be much either than having a climate change agreement with some teeth. I have been doing climate negotiations a few years ago, and some of the issues
What's
are
more
quite
difficult,
simple.
that or the pandemic negotiations? And so
Probably the climate change is probably more difficult because it's affecting more sectors, and it's more broader. But the idea, I think some of the problems are the same problems. So in the climate negotiation, it was always, you know, who does which part, and we need everybody to do something. Then the others say we don't have the means, give us the means to do it. Then the others don't want to give the means. So it's a very then you have other priorities. Yeah? Other countries could say, look, I don't have any vaccines for the really deadliest diseases. Why should I now focus on COVID, which is in my young population not really causing a problem? Some of the themes are the same. The worst, actually, just to finish, is if I make a connection between both. I mean, in Israel, right, they have now boosted almost everybody because they cannot reach also parts of their population. They have pockets in the population they cannot reach. So what they do is start to vaccinate the rest again. But I think I have read today that at least some people said actually it wasn't the boosters that have brought down the infections there. It's probably because it got warmer and now it gets worse. So in a world that is 3-4 degrees hotter, maybe we would have less problems with
this pandemic.
With this pandemic,
probably
yes.
With another pandemic.
But I think I would still, you know, on the one hand, you know, there is a big push now to say, you know, the best moment is in a crisis, right? We now have the attention of global leaders on global health, and let's now, you know, have do a big treaty, try to solve all the issues before the political attention starts moving to other things. There's value in this argument. There are discussions in Geneva now for the next World Health Assembly, end of this month, early next month, to start such a process for a comprehensive global treaty on pandemics. But on the other hand, you could also say, you know, let's focus on the simple things we can solve, on the practical things, and let's not try to get lost 10 years negotiating the definition of equity in global health. So I think you need a mix of both. I actually am very keen in this pandemic to actually get things done. So I'm doing both. I'm working on declarations and papers and political things, but then I'm also working on very concrete practical things. And for example, we did this support for India when it was even big in the news, I think, last year, when we said this was one of the best moments, I think, in my work, when I could see the German army flying to India, bringing the huge equipment to produce oxygen right there in the streets, and the ventilators, which were taken directly from the airport directly to the hospitals, and immediately people, put on oxygen there and saving lives. And this was a very concrete thing that actually, although it makes a lot of work, was quite satisfying. Or sometimes it's more satisfying than saying, I have managed to get a commitment that in 10 years maybe we will do this or that.
Mr. Shaikh, but because the question was about better structures for public health, what's probably your idea?
Yeah,
what's the most important thing there?
So I think one of the things was, how do we sort of get to this increase in trust and, build better structures? I think 3 simple points I have is, one is you need to understand, or we need to understand, that trust it's a continuous evolving and, it's a dynamic process that we're engaging in. A lot of the things that we're seeing now are not problematic or did not occur during COVID. It was because of the mistrust due to the actions we took before the pandemic started. So I think what you do today is going to have an impact on that trust tomorrow and also in the future. So it is a continuous process. There has to be continuous investment in building that trust up, which means as governments, you need to deliver on your commitments. That's the most important thing, not just with regards to the pandemic, but with any other commitment you make. Just deliver on those, just act on it. And I think the second point would be to somehow engage more with citizens. It is not that we only want to engage during the pandemic and share information. All the other decisions that you take about people's health and the healthcare system, on the financing of the system, on the service delivery in the system, how engaged are citizens in those decisions or in developing those structures? They are not really engaged in that. So I think that's very important, to engage citizens right from the beginning. Switzerland has a referendum on everything. Yeah, and I'm not saying you have to have a referendum on everything over here, but you need to build structures where citizens can participate and they have a voice, and most importantly, that voice matters. There are structures in Germany where citizens can come in and say that we would like to have this and we would like to have that, but there are no real voting rights in that case, right? So how are we going to make sure that they have a voice and that voice is counted? I think that's one step towards building trust, because then you feel that you're a stakeholder in the process. You own the process, and what you do will matter to that process.
Okay. Mrs. Schmelz, probably the question, to widen the question a little bit, the role of science is very important also in the pandemic, and the Viscom, we call it in German, the science communication. What do you think do we have to improve there? Because it's also about trust.
Yes, that's true. And in the pandemic, science was important and has partly been related to politics, because scientists have advised politicians and so on. For scientists, I remember when a bit earlier in my research, it's weird to talk to the public. When I was doing my PhD at the Max Planck, the person in charge said, "Oh, it's a waste of time to talk to the public, do your research, you have to publish." And I think in Germany, or at least in my field, I don't know about other fields, but there is some, in the past it has not been really valued. And in the pandemic, personally, I realized how important it is to be able to transmit and to convey your ideas to the public. And I've experienced myself this challenge, but it's really valuable if you can do that.
And the question to you is how can we have more positive narratives in times of crisis? Because that's also probably about trust, huh?
Yeah, a very big question. Let me maybe pick up on the science communication question. We actually also had one part of our third module, I think the third wave of the panel study, was about science information.
Okay.
And I think what happened that you alluded to early on and with the AstraZeneca is the misunderstanding of the public for the general process of science knowledge accumulation, right? So basically there was a study, there was another study, and there could become new data available. So basically the conventional wisdom or the conventional knowledge about the efficacy and the risk of AstraZeneca just changed because it was updating, just updated information due to novel evidence that was available. And that, I think,
that was difficult to understand or to cope with.
Yeah, exactly. So actually we were in the field, also was in the field right at the time when that communication disaster basically happened. And you could see that there was really a loss of trust over time, over the fielding period of our survey. And this is really indicative of the insecurity that arose during that time because of that novel information that became available. So I think we really have to work generally improving science communication, but also increasing the general understanding of how science worked, right? If we get new evidence, new studies available, new data available, that then knowledge changes as a natural result. And the same with climate change. I think this is very similar in that regard. There's a lot of fake news and misinformation going on, and voters, the society in general, I think, is to some extent receptive to these fake news simply because they lack an understanding of how science works generally. And I think here at the very notion of the science accumulation process, really have to start and try to inform, better educate society on how science actually develops knowledge.
Okay, a lot of work to do. Are there more questions from the audience?
Hi. I have a question for anyone on the panel, but I was interested in the controversy surrounding ending the free Schnelltest program before the European winter, partly because of the cost, but also because of Zweige. And however, it may have also had the unintentional effect of discouraging the amount of testing going on in the already vaccinated community. So in retrospect of that, do you think that was still the right decision?
And
the timing
they
of
think
that?
to go back to free tests, I guess, huh? There's a discussion going on. So what do you think?
Yeah, we don't really have any data yet. At least I'm not aware of this. But I think it totally makes sense. The mechanism that people are suggesting that testing is going down because it costs a lot of money, right, to get tested now. So people are simply trying to avoid those costs. It's like, it's like a negative cost essentially for getting tested. And for instance, very practically, I see that I'm head of department at the Institute of Social Sciences here, and we have 3G. And I get complaints of students because they don't want to get vaccinated, but they also don't want to pay for tests. So we don't have the resources to test, to actually check the status of every student entering our premises. So presumably many of them are not tested simply because they avoid the cost, they complain about this, and this could cause a lot of trouble. So even though there's no data, I could imagine that something like this is going on that explains why we have less testing and to some extent higher incidence also.
Okay. Yeah, there's time for another question.
This is one for Mr. Bergfelder. You referred to the availability of the so-called inert vaccines, the dead vaccines, and that we may have more ability to reach some of the hesitant people if they are to become available. I'm just curious if you have any figures on that. Like what in the hesitant population, what percentage are we looking at there?
I think I have to thank you. May I take this one?
Yes, of course. Yeah, it's for you.
I think I think there is you simply have to look it up in the internet. I think there was a Forza survey published a week ago.
Yes.
And I think that this counted for almost half of the people who haven't yet taken the vaccine. hesitant and opposing that. They said this would be the factor that could, the only factor that could change their mind potentially. Obviously, you know, you never know whether that's true or not, but it was more significant than I had thought beforehand. And I know that the Ministry of Health has, especially also for these reasons, actually bought this vaccine. But we don't have it yet on the market. Let's see, you know, probably Mr. Kimmich could be a popular example of these, saying, I need all these long-term studies. This goes into the direction of, oh, these modern vaccines, we don't know. Whether that's true is obviously another issue. I mean, they are not that new, these technologies of the vector vaccines and the mRNA. But the other one
vaccination isn't that new.
But let's see. I'm also think one of the colleagues here mentioned that, you know, one question is, or one issue is what you have in the survey, and then the other is what actually was the firefighters or the policemen in New York. When push comes to shove, how will people really react? And if you look at the news for the Schnitzel panic in Austria, Schnitzel panic, maybe we can have a similar Schnitzel panic in Germany if the rules are also not only postulated but actually also enforced.
So what's in Germany, Schnitzel panic? Thüringer Wurst panic?
I don't know what.
I'm a vegetarian, so.
But we are not really. I mean, are we really controlling this 2G, 3G thing?
We are debating it.
No, but are we actually
no.
controlling?
In Berlin, I guess. I have the experience. There's not much of control.
But I think that's the crucial thing. If something is enforced, then it has to be enforced. If it's mandatory, it has to be enforced.
Yes.
And as long as the implementation power is limited, why to make it mandatory? Mm-hmm. Then rather build on voluntary processes. Mm-hmm. And it also depends on the power of government to really enforce certain things in our democracy. I mean, vaccination, but also other aspects and other things.
That helps to build up trust also, I guess.
It helps to build up trust, but also it's useless if you implement it mandatory, but you don't enforce it. Yes. It makes no sense.
No, that's right. Are there any questions left? Because we have only one question, the last short question, because we're a bit late, running out of time.
Well, thanks for taking the last question then. I wanted to ask the panel about not the skeptics and the people who refuse to take the vaccine, but the people who have already done so, the 80% of, I'm assuming the majority here that have gotten the jab. What do you tell these people? And isn't there a moment when their patience also runs out with the minority of people who hold out, who don't want to be, or who can't be convinced to take the vaccine? And so one part, the patience, and then on the other hand, isn't there also a moment when we lose trust in our governments to actually have the power to bring these people to reason?
Yeah, it's a very good question. Thank you very much.
Maybe I can take this one. I mentioned that we had this latest study in September, and we were precisely interested in that question, right? To what extent does public opinion generally support, for instance, further restrictions for those not vaccinated, right? Because what is the alternative? At some point, we may actually face the problem that we have another lockdown. And would the majority of those willing to get vaccinated actually support this? And what we see is they're generally in favor. There's a vast majority that is in favor of reducing the freedoms for unvaccinated, while actually leaving freedoms for those who are vaccinated instead of a general lockdown. And we also see that if governments wouldn't adopt such 2G rules, they would actually lose trust in their government. So, and this is by far the largest majority. In our survey, similar to the one that was run by the RKI, we find 84% vaccinated among the adult population, and we said there's a significant loss of trust among those who are vaccinated, who complied, if we don't do anything about it, right? So I think you have a very fair point that we completely ignored so far in the discussion, that we can also have a loss of trust among those who were complying. So I think this is also a very good argument for actually going further and adopting, for instance, 2G.
Okay. So you're a fan of 2G?
No, Just quickly, I think I have a lot of sympathy personally for what you are suggesting, and the reality is already in hospitals that most of the people who are now in intensive care are unvaccinated people, and we are starting to see operations again, you know, being pushed. I'm not even talking about the money that we are basically paying for the care of these people, unvaccinated, but we can see operations being delayed from other people. And the next thing, obviously, personally also as father of children, you know, what this lockdown, school lockdown has done to my children for 2 years now, I think I personally I would have a big problem for another lockdown in the winter, especially if it would be, you know, reason, oh, we cannot enforce vaccination on teachers. Sorry, there are so many unvaccinated teachers. We cannot keep school open. I don't know really how I would react to that. Mm-hmm. So I have some sympathy for this, but this is my personal opinion. Okay. But nobody should, you know, trust in government is important, but also you should not, you know, it's not safe to always fully believe what your government has promised, you know.
Trust yourself. It's probably a good idea.
If you say my government has promised there will never be mandatory vaccination, you know, we have to adapt to circumstances. Yes. I cannot, you know, cannot say how this will look like in 2-3 months.
Mr. Schmelz?
Yeah, I think part of the situation for the vaccinated who have done the proper thing early and so on is also what does it signal? So a government's decision of, or if people who are not vaccinated think it's voluntary, so it's okay to not do it, I can test instead, that's not what it is about, right? And the government's rules signal what the social norm and the right thing should be. And in this sense, yeah, again, we have to, or the government has to think hard how to make it happen.
Mm-hmm.
I fully agree. My biggest, concern is if there is another lockdown, what are the people that got vaccinated going to think about it? We did everything we had to do to get vaccinated.
I go crazy.
And now you're imposing another lockdown on us because of someone that didn't want to do it. That also ties in what was asked before about paying for the tests, because at the end of the day, it's taxpayers' money. A majority of the people that got vaccinated are paying for someone else's test. The usual argument that people that don't want to get vaccinated have is, it's my body, my risk. Well, then it should be your body and your cost. So you pay for it as well. So if someone that is vaccinated wants a test, I think they should get a free test. Because it's not like, you get the vaccination and you cannot have COVID. Mm-hmm. There are instances where you can have that. So if you're vaccinated, I think you still deserve a free test.
Okay. So thank you very much for your questions, for your answers, for your thoughts and your studies and your engagement. Thank you very much to Heike Klüver, Katrin Schmelz, Mujaheed Shaikh and Martin Bergfelder. So thank you very much also to Scripts, the Cluster of Excellence Condensations of the Liberal Script, and the Humboldt Lab that we could be here at this wonderful space. Thank you very much here at Berlin Science Week.